Good afternoon. We're going to discuss today from beta blockers up to parasympathetics nervous system. To continue on beta blockers or beta adrenergic blocking agents, which are also called, or beta adrenergic receptor antagonist, is basically a group of medications who block the action of endogenous catecholamines. And remember, those are your epinephrine, norepinephrine, and they do that on adrenergic receptors. In this case, will be the beta receptors on the sympathetic nervous system, which basically remediates the flight or fight response. Remember that you have three types of beta receptors, and those are known: beta 1, beta 2, beta 3. Beta 1 adrenergic receptors are located mainly on the heart and in the kidney. Beta 2 adrenergic receptors are located mainly in the lung, gastrointestinal tract, liver, uterus, vascular smooth muscle, and skeletal muscle. And B3 or beta blockers 3 are in fat cells. So beta receptors are found on cells of the heart muscles, smooth muscles, airway, arteries, kidney, and other tissues that are part of the sympathetic nervous system and lead to stress response, especially when they're stimulated by epinephrine. Beta blockers basically interfere the binding to the receptors of epinephrine and other stress hormones, and basically weaken the effect of these stress or hormones. They're a group of medications that are particularly used for the management of cardiac arrhythmias, myocardial infarction, hypertension, angina pectoris, heart failure when it's not over or acute. In addition, you could use beta blockers for arrhythmias, mostly tachyarrhythmias, with um, mainly with a P being present. Also, it's used for glaucoma, as we already covered. For hyperthyroidism, because if you remember, in hyperthyroidism, there is tachycardia as one of the symptoms, so you could control that tachycardia with a beta blocker. In addition, there's off-label use for alcohol withdrawal, aggressive behaviors, akathisia, which is very similar to tardive dyskinesia, essential tremor, and anxiety. Beta blockers are also used in combination with hydrochlorothiazide, because you remember thiazide diuretics are the first line treatment for hypertension, and when combined with propranolol, is called indiuretic. So, um, for the pharmacodynamics of beta blockers, I already said that the location of these receptors are in the heart, um, to control the heart rate, to control myocardial contraction. They're also found in the respiratory system. Uh, so patients that have asthma, acute status asthmaticus, or acute bronchospasm, um, you need to give beta blockers very cautious. And if you will prescribe a beta blocker, remember, as we already discussed, it's better to give a selective beta blocker. Remember that because beta blockers will blunt the response of epinephrine, norepinephrine, and neosynephrine, which are your sympathomimetic neurotransmitters. Patients will have a blunt response to hypoglycemia. So it will blunt the signs and symptoms of hypoglycemia. In addition, talking about metabolic and endocrine effects, beta blockers will inhibit lipolysis, basically resulting in increased triglycerides and cholesterol. So this is a downside for beta blockers because it will increase hyperlipidemia, um, and may worsen this condition. In addition, beta blockers will inhibit gluconeogenesis and glucogenolysis. So The new sources of glucose to be obtained in the presence of stress will not happen. That will restrict glucose uptake and also inhibit insulin secretion, worsening hypoglycemic event. We already discussed another effects of beta blockers that would produce depression because remember that serotonin is one of the sympathomimetic neurotransmitters, and beta blockers will blunt the action of all the sympathetic neurotransmitters and will worsen the symptoms of depression. One of the side effects for beta blockers as well is sexual dysfunction and impotency. So it's one of the first leading cause of non-compliance for male patients. For main cardiovascular effects, being a beta blocker, it will block the action of a sinoatrial node. So patients would have decreased heart rate. They would decrease contractility. Also, in addition, there was low conduction of the AV node, producing blocks. Patients would have decreased cardiac rhythm, so it's used for tachyarrhythmias. They would decrease both supine and standing blood pressure. Give me a second. Um, in the vascular system, basically will produce vasodilation. It will decrease peripheral vascular resistance. In addition, we already discussed that in the renal effects, it would reduce the release of renin and as well as angiotensin 2 and aldosterone, but not to the effect of ACE inhibitors. And also, I cannot emphasize more that at the level of the respiratory tract, it could produce bronchoconstriction. So every time you would order a beta blocker for a patient that has acute bronchospastic episode or status asthmaticus, you must do selective beta blockers, which are the main metoprolol and atenolol. So how does beta blocker will decrease the stress response? Remember, once the beta blocker will enter the gastrointestinal tract, it will prevent adrenaline from attaching the receptors of the heart, and that will prevent the fight and flight response. So patients with hypoglycemic event would not be able to feel the jittering, the sweating, the nervousness, all the signs and symptoms of hypoglycemia. You have again selective beta blockers and non-selective beta blockers. If you're only targeting heart conditions and hypertension in a patient that has a bronchospastic episode, try to use selective. And the most common use are your atenolol tenormin or metoprolol lopressor. In addition, you could use acebutol or bisoprolol, but the ones that are more economic and mostly used outpatient and inpatient is atenolol and metoprolol. Non-selective, you could use for other conditions, including hypertension, but not related to respiratory conditions. Propranolol, Inderal, Timolol, which is first-line treatment for glaucoma, mostly open-angle glaucoma, and Nadolol, which is Corgat. In addition, you have a combination of alpha and beta blockers, which is less likely to decrease heart rate and cardiac output. And this is basically given for patients that are after a myocardial infarction and after acute event of heart failure. And these are the combination of alpha and beta. And the one that is mostly used is carvedilol coreg, and also labetalol, either PO or IV, which is used for hypertensive urgencies and emergencies. Both, either selective or non-selective, they have beta adrenergic response being blocked. Selective, of course, more beta 1. If you remember, beta 1 is the one that gives you the chronotropicity, the dromotropicity, and ionotropicity. And the non-selective, basically, they block beta 1, which is cardiac, and beta 2 is the smooth muscle of the bronchi and the blood vessel. So, this is the reason why non-selective beta blockers should not be used, or if used, are very cautious in patients with asthma, not only as a history, but when the acute bronchospastic event is present, exacerbation of COPD, as well as status asthmaticus. Combination of one and alpha 1 and beta blockers basically promote arterial and venous dilation, reducing heart rate and myocardial contraction. They impede action of the catecholamines, as we already discussed, decrease cardiac output, decrease heart rate, and also decrease in blood pressure. The beauty of beta blockers is that reduces oxygen demand and produces a balance between demand and supply, decreases contractility, and coronary blood flow is improved. This is one of the reasons why it's the drug of choice for angina pectoris, either stable or unstable. But remember, it's also used for hypertension because it reduces morbidity and mortality, and is now available, as I said before, with a combination of hydrochlorothiazide, which is the first line treatment for hypertension. It's used also for post-myocardial infarction prophylaxis because it decreases mortality. It limits the infarction size, it prevents primary arrhythmic events, and also subsequent ischemia. In addition, provides a protection for recurrent coronary occlusion. Suppresses renin release, so the compensatory mechanisms for angiotensin 1 to conversion to angiotensin 2 and aldosterone release does not happen. Blocks cardiac pacemaker potential, giving a high risk for bradycardia. Now, because of this, since there's a blunt response of compensatory mechanisms, uh, um, beta blockers should not be used in acute pulmonary edema or every time the patient is in overt CHF, because by blocking the beta 1 receptors, you would decrease ionotropicity, putting the patient at risk for pulmonary edema, respiratory failure, and death. Beta blockers are highly metabolized through the liver, so you must monitor LFTs, as well as is highly excreted through the kidney, monitor BUN and creatinine, and basically measure baseline of BUN and creatinine as well. You must monitor the blood pressure and pulse. This one does not give you high risk for orthostasis, because it does decrease systolic and diastolic in equilibrium, proportional. But you must measure blood pressure as well and heart rate due to bradycardia complications, and this should be done weekly. EKG must be done baseline because you must monitor if the patient has sinus bradycardia and also including blocks. If the patient goes in overdose, this is one of the factors that you will um, be able to monitor in the EKG. Remember that beta blockers inhibit glucogenolysis and gluconeogenesis, so patients are very high risk for hypoglycemia, and not only that, they blunt the signs and symptoms of it because impedes lipolysis and produces lipogenesis. Patients could have elevated triglycerides and lipids, so you must monitor lipid panel as well. And if it's elevated, of course, treat with lifestyle modifications and statins if they're not contraindicated. Monitor for toxicity and signs and symptoms of beta blocker overdose, which we have a case after this, is bradycardia and hypotension. It also masks signs and symptoms of thyrotoxicosis. Remember that hyperthyroidism will give you, as one of the main side effects or symptomatology will be sinus tachycardia and tachyarrhythmias. Because this is produced by the augmentation or secretion of adrenaline and noradrenaline by having high metabolism, by having elevated T3 and T4 in the system. the beta blockers will blunt the response of these neurotransmitters, and the patient would not be able to feel the tachycardia and the palpitations. And for the provider, it would be very difficult to assess signs and symptoms of thyrotoxicosis until it's late. Atenolol is a category C. Only sotalol, pindolol, and acebitol is a category B and can be given to the pregnant woman. Uh, Cost effective, the least expensive for your pharmacoeconomic independent study. Um, Always try atenolol, metoprolol, and propranolol first, um, because they're cheaper. So we already went through what do you have to monitor, how do you educate the patient. This is a case scenario regarding beta blocker toxicity, and this is the 56-year-old male presenting to the ER with decreased responsiveness. So lethargy or somnolency or even obtundation. Wife who's with him states that she found him on the kitchen floor in this state. He has a medical history of hypertension and depression. He was on duloxetine, which is Cymbalta, and this is basically given for patients with depression, and also is the medication that is given to patients with neuropathic pain and fibromyalgia. Is serotonin and norepinephrine reuptake inhibitor. So the patients would have high levels of serotonin and high levels of norepinephrine, which basically counteracts the effect of low pressure, occupying the receptors, and low pressure being a beta blocker going into toxicity. So the patient is lethargic, having hypotension. Um, the glucose factor here, the level is within normal limits, but being on the beta blockers and having hypotension and having altered mental status is a very high indicator of um, beta blocker toxicity. So if we're going to discuss a little bit more about beta blocker toxicity, um, basically what happens is that uh, patients will be comatose, they're lethargic, they since a beta blocker competes with catecholamines, um, this decreased the production of the CAMP, and patients would have reduced heart rate as this patient has in the 50s. In addition to that, blood pressure will be decreased, which is 80/50, mostly systolic, even though it does decrease both at the same time. Myocardial contractility will be decreased, myocardial oxygen consumption. Uh, Beta blockers also inhibit relaxation of the smooth muscle um, in the blood vessels and also in the musculoskeletal. So patients could go into rhabdomyolysis as well, even though this patient has no evidence of it in laboratory data. But there is fever. So that is the factor of not allowing the skeletal muscle to relax properly. Um, You have here an EKG with basically blocks. It could present with any type of block from first degree up to third degree AB block. So what's going on in this scenario is that a patient has beta blocker toxicity. It could happen with any patient presenting again with bradycardia, with CNS symptoms, which is decreased level of consciousness up to seizure as a result of cellular hypoxia and poor cardiac output. Patients could also present with bronchospasm, even though this patient is not having this symptom. Um, it's a actually rare complication that could lead to fatality, but again, this patient does not have that. Um, Differential diagnosis for this patient, it could be actually serotonin syndrome, which is antidepressant toxicity. In this case, the problem is that fluoxetine Cymbalta is competing with the receptor for the beta blocker. So the patients could go into beta blocker toxicity or serotonin syndrome, which is an antidepressant toxicity. So to be able to treat beta blocker overdose, you give glucagon. And glucagon basically reverses hypoglycemic event, and in addition has a positive inotropic action on the heart and decreases renovascular resistance. If this patient is at high risk of having rhabdomyolysis and renal failure associated with beta blocker toxicity or even serotonin syndrome, uh, glucagon will prevent that. In addition, you could put the patient in cardiac pacing if it's severely asymptomatic. Patients who experience bronchospasm due to beta blocker toxicity could also be treated with this, and also they could be treated with ipratropium bromide. Now, let's discuss about cholinergic agents. And if you remember, whenever we say cholinergic agonist, it's the same thing as saying parasympathomimetic or muscarinic agonist. We have direct acting cholinergic drugs and indirect acting cholinergic drugs. If you remember, you either increase the metabolism of production of acetylcholine, or you avoid or inhibit the release of cholinesterase, which is the enzyme that catalyzes or breaks down the acetylcholine. So by inhibiting acetylcholinesterase, you would have more acetylcholine. So for the direct acting cholinergic drugs, we're going to discuss the Bethanechol and also pilocarpine, which is for the treatment of glaucoma, and Bethanechol is for the treatment of urinary incontinence. And for the indirect acting cholinergic drugs, we're going to discuss the cholinesterase inhibitors, which is neostigmine, prostigmine, which is for the use of myasthenia gravis. We discussed this already in class. Remember, the muscarinic peripheral effects are the excitatories, and they're excitatories for parasympathetic system, which the parasympathetic system is already the one that counteracts the action of norepinephrine, epinephrine, and dopamine and norepinephrine. So the patients would have everything slow and low, and also in addition everything wet. So the patients would be mostly in bradycardia and in heart blocks. Patients could go into cardiac arrest. They would have meiosis. They would have everything wet with lacrimation, with rhinorrhea, with bronchospasm, bronchorrhea, rales. They would have excessive salivation and also diarrhea, vomiting, and abdominal incontinency. If we talked about the CNS disorders, since muscarinic effects are mostly everything slow, patients would have lethargy, lethargy, somnolency, up to coma and respiratory depression, and patients who would have nicotinic effects being enhanced. It would be mostly fasciculations, hyperreflexia, myoclonic jerks, seizures, delirium, irritability, psychosis, etc. And instead of everything wet, everything will be dry. So they would have dry mouth, dry skin, dry eyes, which is called xerostomia. And in addition, instead of having everything slow like the muscarinic, they would have everything fast. So they would have tachyarrhythmias and sinus tachycardia, of course, and these rhythmias, but mostly for the fast type, which is AFib and aflutter. Examples of muscarinic agonist is carbachol, myochol, pilocarpine, bethanechol, and also methacholine, which remember I already mentioned that methacholine is used for bronchospasm trigger in patients that are not responding or difficult to diagnose bronchial asthma. So you basically could provoke the bronchospasm, in, of course, in a very well controlled environment with methacholine. So what are the main uses of cholinergic drugs? Is basically for glaucoma. In addition to that, to treat the atonic of the GI tract and the urinary bladder, to diagnose and treat myasthenia gravis, and as I said, for hyperresponsiveness of the bronchial airway with methacholine to be able to diagnose bronchial asthma. If you remember, I discussed already as well, muscarinics will contract the detrusor muscle of the bladder, and nicotinics will relax the detrusor muscle of the bladder. In addition, who else relaxes the detrusor muscle would be the sympathetic system. So basically, they're located in the bladder. But in addition to that, muscarinic agonist will control the autonomic and somatic response of the pontine and cerebral cortex. In addition, the urethral sphincter. And as I told you, remember, mainly what happens is that who controls the relaxation of the bladder will be the sympathetic nervous system, and the parasympathetic nervous system, mostly the muscarinic, will contract. Now let's discuss the urinary incontinences. Urge incontinency, the patient, what happens is that the muscarinic, which contracts, has an overcontraction. So this patient has a little bit of urine in the bladder, and since the muscarinic is contracting constantly, the patient has the urge to urinate, and when they go to the bathroom has a little bit of urine with bladder spasm. So since the problem with urge incontinence is the muscarinics are contracting constantly, what you have to do is provide a cholinergic inhibitor or anticholinergic drug to be able to treat that, or give a sympathetic agonist since the sympathetic relaxes. Stress incontinences, we discussed in class that this is the pregnant woman that delivered and the pelvic floor is weakened. So no medication is given for stress incontinency. Mainly what you have to do is Kegel exercises. This is the person who by cough, by sneezing, or by having pressure in the abdomen during exercise, for example, has leaks of urine. Overflow incontinency is mainly the sympathetic nervous system is too relaxed, or there is inability of the muscarinics to contract. So the bladder is getting full up to the point that it overflows. So to be able to treat overflow incontinency, since the sympathetic system is too relaxed, you have to do beta blockers or provide muscarinic agonist. If you provide cholinergic agonist or muscarinic agonist, which is the same thing, you will contract the bladder and the patient will urinate and avoid big amount of urine being accumulated and have more residual volume and UTI, and most likely as well having hydronephrosis and renal failure in the future. Functional incontinency, this is the elderly patient that because it's confused or have no access to the bathroom, they have leakage or they urinate in the bed. Mixed incontinency could be associated with urge, associated with stress combined, or overflow with urge combined. And again, these incontinences could be transient or permanent. So how are we treating the patient? You could give anticholinergics or antispasmodic for urge incontinence because they basically block the muscarinic action. And by inhibiting the acetylcholine, they will provide bladder smooth muscle relaxation, and it will decrease the detrusor overactivity. The cholinergic agonist is mainly for overflow incontinency, because remember, for overflow, the bladder is too boggy, it's too relaxed. So what you have to do is stimulate the cholinergic fibers or muscarinic, which is the same thing. Basically, what happens is that by doing this, there is a release of acetylcholine, the detrusor muscle tone will be increased, and the bladder will contract. In addition, you could use some additive of treatment, which is desmopressin, vasopressin, and also analgesia, such as pyridium, for example. But this is mainly for dysuria. Now, this is everything that we said. Bethanechol, that increases the tone of the detrusor muscle, so it's a muscarinic agonist or cholinergic agonist that causes bladder contraction. Now, in addition, what happens is that you have to be very careful with bethanechol because every muscarinic agonist, remember, produces everything wet. And that everything wet also includes the increased secretion of hydrochloric acid in the stomach. So that puts the patient at risk of gastric ulcers, peptic ulcer disease, etc., because it increases the gastric tone and also secretion. Clinical use is mainly for neurogenic bladder atony. Do not use it for patients that have peptic ulcer disease, as I said, or also bladder obstruction. If you have any suspicious factor that the patients could have bowel obstruction, don't give it as well. Because remember, any type of cholinergic, parasympathetic system contracts the GI tract as well. Remember that for the GI tract and for the urinary tract, it's completely backwards. Sympathetic for the GI and the bladder will relax, and parasympathetic for the GI and the urinary tract will contract, which is completely opposite for the rest of the systems. Okay, so patients that have possibility of abdominal pain or any signs and symptoms of bowel obstruction, these medications are contraindicated. In addition, you could do behavioral techniques like the Kegel exercises for stress incontinency. In addition, you could add estrogens or tricyclic acid, as well as for urge and overflow incontinency. Now, when should you refer a patient to a urologist or nephrologist? Well, if the symptoms do not respond after the initial treatment and within 2 to 3 months, if the patient has hematuria, with or without infection, if the patient has recurrent symptomatic UTI because of residual volume increased, because if the patient has, for example, renal failure because of hydronephrosis, if the patient has any subjective or poor bladder emptying, if the patient has vaginal urethral pain or pelvic pain, if there is any neurological metabolic disease, if there is any again, residual volume being increased, or radical pelvic surgery, or prolapse, or prostate problems, etc. Okay, but never before. This is within your scope of practice. You should be able to treat that. Now, another list of medications that could be used as anticholinergic or muscarinic antagonist or cholinergic blockers are your atropine, which is basically your prototype. You also have ditropan. You have cogentin, which is for the arthritic dyskinesia symptom, as well, that you could use Benadryl, Hycosine, Artane, etc. Now, which is your prototype is the cholinergic blockers, or anticholinergic is your atropine, which is mainly for the treatment of bradycardias. In addition, you could use scopolamine, as scopolamine is for the use of motion sickness and also for excessive salivation, is a patch. Another type of anticholinergic is a patropium bromide that is used as a bronchodilator. Benztropine or cogentin, which is again is for extrapyramidal symptoms, and oxybutynin, which is basically for bladder spasm. Other use of anticholinergic drugs. Remember that the main pathophysiology or mechanism of action of the anticholinergics are to block the vagal impulse to the heart. So suppresses or decreases the bladder spasm, respiratory secretions preoperatively, relax the sphincter of the iris, so patients would have dilation of mydriasis, mainly for surgeries, treats tremors for Parkinson's disease, and also treat the side effects of psychotropic medications such as cogentin. Now, cholinesterase inhibitors are used for myasthenia gravis. And remember that the main problem with myasthenia gravis is decreased levels of acetylcholine. So what you would be doing is blocking the enzyme that catalyzes the conversion or production of acetylcholine, having more acetylcholine. And these medications are neostigmine and pyridoxine. In addition, Alzheimer's disease, that one of the theories for Alzheimer's disease is having low levels of acetylcholine. So you could give donepezil, which is also a cholinesterase inhibitor having more acetylcholine, and this will be your Aricept. Now, again, this is mainly the pathophysiology of Alzheimer's disease. And if you remember from pathophysiology, you have a cholinergic hypothesis, you have an amyloid hypothesis, and you have a tau hypothesis. That mainly what applies here for this class will be the cholinergic hypothesis, that is basically due to reduced synthesis of acetylcholine that we already explained. So you could give cholinesterase inhibitors, or also another enzymes that avoids the conversion of glutamate, which is mostly an excitatory neurotransmitter or second messenger, to that is associated with apoptosis. So cholinesterase inhibitors, we already mentioned some of the names. In this case, for example, for Alzheimer's will be the Aricept, donepezil. In addition to that, we already mentioned mestinon, physostigmine, antilurium, or neostigmine, prostigmine for myasthenia gravis. And basically the mechanism of action is that reversibly inhibits acetylcholinesterase in the brain, which is no more than the enzymes that avoids the breakdown or the enzymes that catalyzes the acetylcholine, having more acetylcholine at the level of the synapses. And also N-methyl D-aspartate, which is NMDA, receptor antagonist, which again, as I told you, this is an enzyme that avoids the conversion or degradation of glutamate, which is an excitatory neurotransmitter. And it's also used not only for patients that have Alzheimer's, but also for patients that have attention deficit disorder and neuropathic pain and migraine. This is basically the explanation of myasthenia gravis. And so the principle is to identify depression or delirium, avoid medications that produce sedation or anticholinergic side effects, because you should not be combining any sedative or hypnotics with this type of medications. Or, for example, Benadryl that has as well an anticholinergic side effect, which is dryness, tachycardia, etc. Avoid polypharmacy. Educate caregivers about major side effects. So basically what you monitor is the patient's mental status, because this is one of the main side effects that these medications have, as well like any other before liver function test. So initial side effects that you cannot forget will be bradycardia. So remember that you have bradycardia for the muscarinic agonist, increased secretions because everything's wet. You have bladder obstruction or urinary incontinency. You also have bronchospasm, bronchorrhea. You have decreased threshold for seizures, muscle cramps. Patients, when muscarinic agonist becomes toxic, basically it's the same symptoms but more exaggerated. When the patients have cholinergic crisis, everything's wet. So the patients will have diarrhea, nausea, vomiting, they will have sweating, they would have a lot of respiratory secretions up to collapse and arrest. They could also have hypotension, they could have bradycardia. Okay, and also the difference between cholinergic crisis and myasthenic crisis would be basically the weakness. The patients that have myasthenia gravis they would have an exaggeration of the symptoms of the disease. So as you could see, the patients normally have ptosis, they have jaw drop, and muscle weakness, and they would have an exaggeration of this. Having mydriasis, in contrary with cholinergic crisis, which is the muscarinic agonist being exacerbated, patients would have meiosis, and they would have all the signs and symptoms of overdose of muscarinic. So salivation, lacrimation, urination, and diarrhea. For patients that have myasthenia gravis, you could do tensilon test, which is no more than an anticholinesterase test that is given intravenously, and when it's injected over 15 seconds, patients should have an increase of acetylcholine. Otherwise, they will require an objective assessment of one or more of signs not easily influenced by motivation. So the patients would have ptosis and range of ocular movements. So what I'm trying to explain you here is that you give a patient, if you think the patient has myasthenia gravis, you give endoponium, which is basically the acetylcholinesterase test to have the patient increase levels of acetylcholine. If the patient has myasthenia gravis, the symptoms will improve. Otherwise, they will worsen. For atropine, which is the cholinergic blocker, basically what happens is that you are inhibiting acetylcholine release and increasing the action of vagus. Patients would have scopolamine for motion sickness, ipatropine bromide, as I already explained, benztropine cogentin for EPS, and oxybutyn for bladder spasm. And the last case presentation, this is a 47-year-old female patient who's coming for follow-up to monitor her treatment for diabetes type 2. You add regular insulin to her treatment regimen last month. She tells you that she has not had any symptoms of hypoglycemia with the new plan, and her glucose levels have been in the 60s and 80s. She tells you that her visit to her cardiologist went well, and she was prescribed a new medication, atenolol. So how would you educate this patient? Remember that for a beta blocker and a patient with a diabetic, and even more if you're adding insulin, you have to monitor glucose more closely, because these patients will not feel the signs and symptoms of hypoglycemia. The next time they would have a very low level of glucose, they would have a syncope episode. So that's the main education for this case. And this is the end of this presentation. We will touch bases next class about this pending topic.